Lucy. All right. Great. Welcome back to the House Healthcare Committee. We are still on S37 and we have Planned Parenthood with us today. So welcome, Lucy. And we have asked Planned Parenthood to come in and talk about the services they offer and everything that goes with that. So Lucy, I'm going to turn it over to you to introduce yourself and then start with your testimony.
Great. Yes. Thank you for having me here today. My name is Lucy Lewis, Vice President of Vermont Public Affairs at Northern New England, or PPNNE. I want to express my gratitude to Chair Houghton and to this committee for taking up Bill S37 and for your leadership in doing all that you can to protect patients and healthcare providers, access and provide healthcare to Vermonters. PPNNE is the state's is the largest reproductive health care and sexuality education provider and advocate in Northern New England, with health centers in Vermont, New Hampshire, and Maine. There are 7 Planned Parenthood health centers in Vermont, and last year we served 16,000 patients. Our services include abortion services, birth control, cervical, breast, colorectal, and other cancer screenings, erectile dysfunction treatment, follow-up services for abnormal Pap tests and HPV, which is human papillomavirus, initial infertility workup, miscarriage care, trans-inclusive health care, including gender-affirming hormone therapy, STD testing and treatment, and prevention services, and well-person checkups, and more. One thing I would like to emphasize is that many people of reproductive age, really their primary concern is reproductive health care. And so for many of our patients, we are their only healthcare provider and provide primary health care for them. For the second year in a row, PPNNE was named a 2022 Human Experience Guardian of Excellence Award winner by Press Ganey. PPNNE partners with Press Ganey to measure patient satisfaction through after-visit surveys. Annually, Press Ganey ranks the top hospitals and health systems across the country and recognized PPNNE for our outstanding performance in the category of patient experience. PPNNE was in the top 5% for patient experience out of more than 41,000 healthcare facilities that Press Ganey evaluates. PPNNE is the only Planned Parenthood affiliate across the country to be recognized in this category and is just one of 3 healthcare providers of any kind to be recognized from this region of Maine, New Hampshire, and Vermont. PPNNE Health Center clinicians include physicians, physician assistants, nurses, and nurse practitioners. All clinical staff in our healthcare centers practice compassionate, non-judgmental, patient-centered, evidence-based healthcare within the scopes of practice and according to the license to practice in the state of Vermont. PPNNE physicians and physician assistants are regulated by the Board of Medical Practice within the Vermont Department of Health. The Board of Nursing oversees anyone with a nursing license, such as nurses and nurse practitioners. To assure patient safety and the highest standard of care, Planned Parenthood performs credentialing at hire to validate applicant credentials, including licensure and other qualifications provided in their applications for employment. We re-credential all clinicians every 3 years thereafter. Regarding ultrasound specifically, I know that this was a topic of testimony and it sounded like this was something that you wanted me to expound on a bit. Regarding ultrasound specifically, within our medical protocols, PPNNE has an internal quality assurance program and privileging process that is overseen by the program director of ultrasound. It consists of guidelines, training, and sign-up processes and annual performance proficiency for ultrasound. Ultrasounds can be performed by any privileged healthcare center staff, but only advanced practice clinicians and physicians are authorized to interpret ultrasounds. PPNNE adheres to all relevant federal laws. A patient bill of rights is posted prominently at the entrance to all of our health centers. Any healthcare facility that bills insurance must comply with HIPAA for patient data protection and confidentiality. Because they do not bill insurance, crisis pregnancy centers are not subject to HIPAA regulations. That means that patient data and privacy could be at risk without a patient's knowledge at crisis pregnancy centers. PPNNE maintains CLIA or CLIA certification. That means Clinical Laboratory Improvement Amendment. CLIA certifies compliance with all federal laboratory regulations, and we get formally reassessed every 2 years. As a recipient of federal Title X funding for family planning services, PPNNE counsels patients on the full range of options regarding a pregnancy. PPNNE has required staff training on how to provide this education in an unbiased manner, and I want to emphasize that we make sure that our training is non-judgmental and that we're not pushing patients into any particular service. And we make sure that all patients understand all of their options when they are faced with any kind of diagnosis. PPNNE advertises. Oh, and I should also say that our operating procedures require patient education and informed consent from all patients for all healthcare services. This is critical to our practice, and this is mandatory and basic to our care. PPNNE advertises on several different channels to reach established and potential patients. These include Google search and display, social media like Instagram, Snapchat, Facebook, digital placements on relevant news sites such as 7 Days, streaming services like Spotify, and at times more traditional advertising platforms such as radio or television, depending on the patients and who we're trying to reach and the services we're promoting. With regard to advertising, ensuring medical accuracy in our advertisements is our top priority. Long before we get to the point of placing an ad, our proposed design and language is sent to a clinically trained staff member who reviews it for accuracy and approves the ad before it is placed. They also review the landing page of our website for medical accuracy. Each advertising platform we advertise on also has its own set of rules about advertising health services. Google Ads, for example, makes advertisers like PPNNE go through a certification process in order to advertise abortion. We had to apply for this certification and be approved by Google. Our ads on Google now display a mandatory ad disclosure that says provides abortion. Crisis pregnancy centers and other facilities that do not provide abortions are also supposed to go through the same process with Google and have an ad disclosure that says does not provide abortions. We have, however, seen that this is not always the case, and sometimes their ads are approved without the disclaimer, creating further confusion among patients. We must also adhere to Google's strict pharmaceutical advertising policies in order to run ads about birth control, emergency contraception, and even antibiotics that treat sexually transmitted infections and UTIs. When it comes to Facebook and Instagram, although we were trying to advertise our health services, the group deemed PPNNE a political organization, and therefore we had to go through a special approval process normally reserved for politicians and legislative campaigns. Staff members trying to place the ads had to be personally vetted by Facebook, which included submitting a copy of their driver's license, as well as receiving a letter to their home address to verify their identity. Despite having the highest advertising standards and following the rules set forth by these advertising companies, PPNNE continues to face discrimination in advertising because of who we are. We've been denied the right to advertise a medicine to prevent HIV through bus companies. We were told by a social media platform that we're too controversial to place ads and have had our ads on Facebook and Instagram denied over and over again, even with the identity approval in place. It takes our staff an incredible amount of time to appeal these denials and set up even the simplest of advertising campaigns in order to get this much needed sexual and reproductive information out to our patients. So PPNNE is really proud of our track record of providing exceptional patient-centered, trauma-informed care to our patients. And this bill is an important step to ensuring that abortion and gender-affirming care remains accessible in Vermont. And we're proud to live in a state where our elected leaders are eager and determined to ensure that people can safely access abortion and gender-affirming care, and that providers can continue offering this critical care with protections from legal and regulatory harassment. We hope to continue working with you to increase access to care this legislative session and for years beyond. Thank you.
Thank you, Lucy. Brian?
So it's great to hear directly from Planned Parenthood after we've heard other people talk about them in the past. I'm curious if you have the statistics of what percentage, and if you don't, it's okay, but like what percentage of the healthcare services are utilized are related to terminating a pregnancy versus how many are used to supporting the completion. I don't know if that's what the word we would use, the culmination, what's the proper word for getting through a pregnancy and not ending it?
Birth.
Simpler than that, right?
Melanie said it first, right?
I will rephrase it. It's like this then. What percentage of healthcare services provided by Planned Parenthood are related to terminating a pregnancy, and what percentage of services are related to
carrying a pregnancy to term?
Carrying a pregnancy to term is exactly what I was trying to think of how to say it. Thank you. All right.
So I don't have those exact numbers because once a patient gets to a certain gestational age, we tend to refer them to an OBGYN at UVM MC or some other local hospital or OBGYN clinic. I will say, relative to your question about our services, I think part of the discrimination that we face in advertising has to do with the fact that our name is synonymous with abortion.
Right. Yeah.
Even though that is really, we are absolutely, we are strong advocates for protecting access to abortion, and we believe that abortion should be available without stigma or shame to patients, and that patients should be the ones deciding their own destinies and futures with regards to their reproductive lives. And but what I think most people don't realize is that about 95% of our patients and services are for what I would consider either contraceptive counseling, contraceptive visits, and basic primary health care, such as cancer screenings.
So,
Thank you. That's very significant.
yeah, I just want to,
Okay.
I just want to make sure I got that right. So 95% of the services that you provide are not abortion related.
That's correct.
Wow.
You were actually not you personally, but Planned Parenthood, when I first moved to Vermont, was my primary care provider. I mean,
Yeah, me too. When I was much younger, I was the only healthcare provider I had.
Yeah.
And that hasn't changed. That's still significantly true with our patients because when you're of reproductive age, reproduction, that's basically your primary concern. And so Planned Parenthood really does serve as a lot of people's primary healthcare provider.
Ellen?
Can you give me the protocol of a minor coming into your services and the timeline before something is done? Normally they're looking for abortion. But what's the protocol and what do you do, pro and con? Do you say, okay, you want abortion, here it is, or we're going to give you some other alternatives? What happens?
Sure. Yeah, thank you for the question. So if a patient comes in, and in this case, not all patients come in looking for abortion, just to be clear.
Okay.
Most do not, in fact. Most are coming in for contraceptive counseling or for some kind of symptom. But when a patient comes in, maybe they've done a pregnancy test already and they believe they're pregnant and they want to know what their options are. Or if they come in and they think they might be pregnant, the first thing we do is we take them in, we do another pregnancy test to ensure they really are pregnant. If they are really pregnant, then they move into a counseling room with a trained healthcare counselor and provider who counsels them about all of their options on their pregnancy. They'll say, "You're pregnant. These are your options." And the options are to carry the pregnancy to term, and we refer to an OBGYN, to have an abortion or to adopt. And in the case of people who want to adopt, we also refer to an adoption agency. All of our clinicians, all of our counselors are trained in unbiased counseling and non-judgmental bias counseling so that no one has to feel like they're being pushed in any one direction or another.
Thank you.
Art?
Just a follow-up to that. Is there an age at which, and I should know the law, but I don't, at which a young lady, a girl, a woman needs permission from an adult to have an abortion?
No, in the state of Vermont, minors can self-consent to seek abortion care. Our standard practice is we advise our patients, or we ask our patients if they have a trusted adult that they would like to bring in to go through the counseling and the experience with them. We ask if they would like to bring in a parent or a trusted adult. And the vast majority of people do choose to bring in an adult to be a support for them at that time.
Okay, what happens in an abortion? You do them at the clinic?
Yeah, we have certain health centers where we provide aspiration abortions, but we also provide medical abortions. Those are abortions that are done through medications. It's a 2-pill regimen.
Yeah.
And those can be done up to 11 weeks gestation.
Okay.
And those can happen with a telehealth appointment, or they can happen in
Yeah,
clinic.
they're pretty horrible.
Have you had one?
No, but I see how they're done.
I'm sorry, I was just trying to make light of it.
Yeah. But what happens with the fetus? What do you do? What happens? Walk me through the whole thing.
I'm going to stop right here because the question is not whether or not abortion is legal in Vermont. Abortion is legal in Vermont.
I'm not saying it isn't.
Okay, so I'm not sure we need to walk through
Okay.
a whole abortion. We can talk about consent. We can talk about counseling and care. I don't think we need to walk through what an abortion is.
How many do you have a medical director at each facility?
We have a medical director that oversees the entire affiliate, and then we have health center managers.
Okay, and where is that located? Where is that
Colch-
individual located?
That individual is, the prior medical director was in Colchester. I believe the current medical director is also in Colchester, but I'm not 100% sure.
All right.
But the medical director is available to all health center staff through telephonic or email, and they also run a circuit. They visit all the health centers.
Okay.
But all health centers have clinicians
They have
who are
clinicians.
trained and licensed to provide health care.
All right.
Yeah.
Alyssa?
I was just wondering if you could talk about your ratio of male to female and what services you provide actually to male patients.
Yeah, we do provide vasectomy services in the Burlington Health Center, and we do provide well person visits for males as well as HIV diagnosis and care. And I'm trying to remember the ratios. I haven't seen the latest data in a while, but I think it's about 17% of our patients are male. And it's growing, and it has been growing.
Any other questions? Lucy, I have one. You talked about counseling, and you also, so we've talked about reproductive health, and you also do some gender affirming care. So can you talk about the type of counselors you have? What are they licensed in?
Yeah, so we have contraceptive counselors who are typically nurses or nurse practitioners, and they counsel people about all of the methods of contraception when we have people come in asking about contraception. And we also have training, and everyone is counseled in how to counsel people about what their options are in the case of a pregnancy.
when somebody receives an abortion after the fact, what's your follow-up and do you continue with
Yeah.
counseling service?
I should also mention that we have a behavioral health structure in place now, and we have certified clinical social workers who are stationed and available in all of our Vermont health centers. In terms of follow-up care, clinicians, the standard protocol is that clinicians will follow up by phone with the patient to see, just to check on them as you would if you came out of an outpatient procedure or something. You're the same as you might have experienced yourself with your doctor coming out of a surgery or something.
Leslie and then Daisy. I'm sorry, Daisy, did you ask for a question a while ago?
No.
Okay, Leslie and then Daisy.
I'm just curious about the ultrasounds and that process that you have there. And could you talk a little bit about that and who your ultrasonographers are?
Sure. So we have a credentialing system in place, or a privileging system in place. Only people who are privileged to trained to run the ultrasound can do that. And then we have another level, only advanced practitioners are allowed to interpret the ultrasounds. We also make sure that we give informed consent. I know that sometimes our patients don't want to see the ultrasound, and we make sure that we're not forcing an image in front of someone's face against their will. That is I think, a really important point to make in contrast to some of these crisis pregnancy centers who I believe do not give patients these kinds of options.
Daisy?
I appreciate that from a mental health perspective. Thank you.
Yeah, for sure.
I also have a comment. I hope it's okay rather than a question, but as someone who grew up in a very rural area, my first foray into women's health was with a local Planned Parenthood. And I can't thank you enough for having access to that as a young woman at 15 and throughout my life. So thank you to the whole affiliate and here in Northern New England. I'm grateful that you'll still be there for my daughter too.
Oh, thank you for saying that.
Great. Any other questions? Art?
Section 8 of our bill talks about, the title is Pregnancy Service Center for I define legislative intent. Did Planned Parenthood have a lot of input into that section of our bill, do you know?
No, in fact, we had advised the Senate that we had preferred a different approach to crisis pregnancy centers. So the language that exists in the bill is definitely not anything that we haven't drafted, or there's none of our suggestions have been adopted in that language.
Did they consult with you? Were you consulted?
I had conversations with the Vermont Medical Society, with the Vermont Attorney General's office, with legislators, with a lot of people who, because in fact, Planned Parenthood is the foremost expert in sexual and reproductive health care in the state of Vermont. And so I think it makes sense that we would be consulted on this bill.
Okay, thank you.
Alyssa, I also wanted to make a comment. My first foray into reproductive health was my local Planned Parenthood. And as someone who did not have a trusted adult in my life at that time, I am incredibly grateful. I had 3 planned pregnancies in my life that resulted in 3 beautiful children. And if it wasn't for Planned Parenthood, that wouldn't have been the case.
Thank you so much for sharing that. It's so moving. Our patients and supporters are people who have experienced our care. I think really can see a difference and can really understand that we give outstanding care. And the Press Ganey Award that I mentioned earlier, that's an incredible honor. When you think about 41,000 healthcare institutions across the nation, and we were one of them in the 95th percentile for patient experience and patient quality of patient care.
Thank you. Tapa?
Thanks for coming in. I have one question.
Sure.
Section 8, the findings. Does Planned Parenthood support all of those findings?
Yes, I find the findings to be absolutely truthful and accurate from my point of view, as I have been educated and have learned about crisis pregnancy centers. Yeah. Yes.
Thank you.
Art.
Do you see the crisis pregnancy centers as a rival or?
No, not at all. We don't see them as a rival because they actually are not healthcare providers. I think our concern more with crisis pregnancy centers is that they operate in a way that is deceitful, and they mislead people. Their advertising is misleading, and they're basically playing doctor, and they're not doctors. You walk into a crisis pregnancy center, often someone will be wearing a lab coat. There's the ultrasound machine. And it sets up a situation where the patient believes they're in a bona fide licensed, under licensed care, healthcare professionals. But in fact, that's not the case. So our issue with crisis pregnancy centers is that we feel like they mislead patients, and they can cause harm. They cause harm to people emotionally and also physically if they misrepresent, for example, the gestational age of a pregnancy. That can be very, very serious. Or if they can lead someone to believe that their ultrasound results are perfect, but in fact they're not because they're not qualified to read those ultrasounds, that can cause real harm to human beings. So we feel very strongly that crisis pregnancy centers are dangerous and should not be allowed to operate in the way that they do.
Do you have evidence of any of that?
We have many people across the country who have experienced crisis pregnancy centers.
I mean here. I don't care about the rest of the country.
I personally don't. I mean, I have never walked into a crisis pregnancy center myself.
Okay.
Didn't we hear some stuff from the Secretary of State about that? The Attorney General?
Attorney General,
Yeah.
yes.
There had been a complaint.
So we are done. Thank you, Lucy. We appreciate your time.
Yeah,
Before we
thanks.
switch to the next topic, I do want to have a quick conversation with the committee. I want to be clear that when we work on bills, whether it's this bill or any of the other bills that we have before us, our job is to seek out testimony from experts in the field. We have Vermont Medical Society in here a lot. We have our own state agencies in here a lot. For those who haven't written a bill yet, yes, sometimes stakeholders really help you write the bill. They give you ideas, they talk you through what's important to them. And then as legislators, our job is to determine what is legal, what is appropriate, and what we want the policy of Vermont to be. So I want to be clear that, yes, we have sought out Planned Parenthood as experts in this field, just as we've sought out Vermont Medical Society and all the other people we've talked to over the last 2 weeks. So with that, do we have our next group in? All right, great. So we're switching to section 9, going back to section 9. So section 9, I'll wait till they come on, actually. Hello, Susan, Shayla, and Veronica. Thank you for coming back. So we are looking at section 9, and just to set the stage for all of us. Section 9 came over from the Senate, and when we first reviewed it, we weren't really sure what they were trying to get at. But the first part talks about AHS shall include access to reproductive healthcare services and access to gender-affirming healthcare services as indicators for equitable access to the healthcare and its community profiles. And then there's a second piece that talks about Green Mountain Care Board and ensuring that healthcare services are included in the health resource allocation plan. So when we had AHS in, there was a request to change the section A to not shall include, but shall consider. And that actually really struck up a very good conversation here about what are we really trying to get to with this? What's our intent? And what can AHS, Green Mountain Care Board, or anyone else really help us with? So I am going to try to express what I think our intent is, and I want those in the room to tell me, and now I've lost all my paperwork, to tell me if I'm accurate. But what we're looking to understand is if people want to access legally protected healthcare, do they have access? And if they don't, where are the gaps? And where isn't there equity in the system? So I want to start with that basic premise. If I'm capturing that right, I'm looking at Topper and Daisy because this is who I've had the most conversations with. I want to start with how is HRAP and how are community profiles used to get to that for everything? Right. So I'm honestly understanding that this probably isn't part of it yet, understanding legally protected healthcare. But how do those reports or profiles help get to a goal like that for no matter what the healthcare service is? If that makes sense. And I'll let whoever wants to go first. And just remember to introduce yourself for the record, please.
Sure, I can start. I'm Veronica Falkowski, Director of Data Analytics Management and Data Integrity at Green Mountain Care Board. And so I think just to get everyone on the same page about HRAP, our Health Resource Allocation Plan, I think we can think of it kind of as a framework or a process to help answer some of the questions about access and healthcare services and costs, et cetera. And so kind of what we would envision for this ask in this bill is to using data that the Green Mountain Care Board has, so claims data and hospital discharge data, but then also utilizing data from our partners, like maybe the community profiles or data that maybe the health department has, is understanding how many people are receiving those services, where are they receiving those services. However, we do know that there are limitations to some of that information. So, for gender affirming care services, we'll be able to answer more of the questions of where people are receiving care, but maybe limited on how we can share that because the numbers of the people receiving those services may be really small. And we have protections around sharing small numbers to protect people's health privacy. We know for some reproductive health services, for example, termination of pregnancy, in claims data, we mask provider data to protect providers. And so utilizing claims data for that specific service within reproductive health care, we won't be able to answer where are people receiving the services, which really would lead to the question about access. And so we would have to be creative or see what other partner agencies have. We do have the hospital discharge data set, which would include some termination of pregnancy data, but that's only limited to hospitals, which we know is a small percentage of those services. So that's kind of how we would use a HRAP framework and process to start answering the questions with what data do we have, what can we show, and kind of starting there and seeing. So I kind of see that as a phase one to help with this ask in this bill.
Okay, so I want to hear from Shayla on the community profiles, and then I have some follow-up questions. And this isn't just for me, so other people can come in, but I do want to go through just a 3-step process before I open it up.
So hi everyone, Shayla Livingston, Policy Director of the Agency of Human Services. So again, I'm understanding your question, Chair, as broadly, how does the agency evaluate gaps in our system of care and identify those and elevate them? Is that?
And how are the community profiles used in that process?
Right. So as the committee pointed out, the last time I testified, the community profiles have not been updated recently because they are grant funded and the grant money that had been supporting them ran out. And we have health equity grant money to support them now for the next year or so. So they are not a staple or critical or essential tool in terms of critical service gap analysis at the agency. They are a wonderful tool and they are helpful and hopefully useful to communities. They are part of the web of data that we try to connect to things like HRAP, the State Health Assessment and State Health Improvement Plan and the Health Department. We hope and wish them to be useful to local communities to evaluate their, most important health and well-being indicators, but they are not our primary way by any means or any stretch of doing gap analysis in care.
So how do you do that?
Great question. So the Agency of Human Services works with our 6 departments, right? And essentially tasks those departments to monitor the care or the services that they oversee and or regulate. So I'll take a couple of examples. DVHA obviously runs Medicaid. So they're responsible for ensuring access to services for their members for the care that is covered and required under Medicaid. DAIL would be a good example for long-term care, right? And their assessment and data systems around long-term care and access to long-term care are what they use to see what the gaps are. When there's problems, when there's issues, those get elevated to the agency. Some examples under COVID, ICU beds in hospitals were a critical thing that we monitored multiple times a day. That data system that we used in that moment and still use now is literally a nurse in an ICU manually reporting that to us. So it's not a data system that will happen over time. That would never go in a community profile. That won't go in an HRAP document. But that was really important in that moment and it's still used at some point in time today. Another example is long-term care beds and mental health beds. You all have heard plenty already about both those systems of care. Those are places where we see a lot of pressure right now and a lot of gap in the system. And we have data and are monitoring that on a regular basis at the agency level. And those departments bring those data to us. None of these data are in one place for an entire system of healthcare for Vermont. So I think that's a really important thing for the community to hear and to know. That's not something we have done. It's not something we can do. It's too diverse in terms of where the data are and live and what types of data you would need depending on the services that you're looking at. That said, we have a vision and a hope to use the Health Information Exchange, the HIE, and interoperability to combine as much data as we can into one place and to start to connect data to be able to do better long-term analysis on patient care. And we have a director, Kristen McClure, who we could bring in and she could do a presentation for you all on what that looks like and what the timeline is. But I don't want you to get too excited because the timeline is not next year. So it's going to take us time, but we are invested in that and hopeful about it and the uses that it could have going forward.
Thank you. So for both, I think when I listen, I hear that you're putting these things together and, for Green Mountain Care Board, HRAP, I don't know who has access to that. And for AHS, you're giving examples that are all within the agencies and then it comes to us. So in both cases, we want to take this one step further and take this gap analysis and this access to the health service area level or community level so that they can see where there's gaps. What can be used for that? And I'll take it one step further. I'm going to go back to Veronica with that question. And also, who has access to HRAP?
Sure. So I will start with your second question first. So right now, HRAP data or different reports that are part of HRAP and not just reports, but also different profiles and assessments, et cetera, are just online on the Green Mountain Care Board website. And so really it's for the public as well. We tend to do most of the kind of looking at services and accessibility and cost by HSA region. So I think that would be the goal. However, keeping in mind that some of these, depending on how we show what is currently, part of access and how we determine to show that, it may be limited to not being able to show maybe by specific geographic regions, but statewide, again, just to protect people's privacy and providers. So hopefully that answers your question.
It does. Thank you. Shayla?
So we use the state health assessment and then state health improvement plan through the health department as a broad-based tool to look at community health. They are also the ones currently doing community profiles, but again, that's not necessarily an ongoing funded operation. The community health assessment and the health improvement plan, there's community engagement, there's, that is actually the same part of engagement that I talked about last time, which starts in May. So they go to communities, they solicit input on what the issues are and where the needs are. Another place you could find that are in the community health needs assessments that the hospitals are required to do under the Affordable Care Act. They go to their communities, they do needs assessments, and Veronica can, or Susan can save me here. I think it's every 3 years. So those are community-based processes. They produce community-based and community-level reporting. So those are two ways that I think are ongoing and systemic that we do that. It again kind of comes back to which measures you're looking for. If you're looking for broadly reproductive health, there's lots of survey data that the health department produces, youth risk behavior, behavioral risk factor surveillance systems, so adults, kids. There's hospital insurance survey data. So there's tons of different data survey tools that the health department collects and reports on that are reported out at community levels on their website. And those are used in a variety of different ways. I know some schools use their YRBS data in an incredible way. So that it occasionally does depend on the community and how the community wants to use it.
Can I just add one thing? So all of what Shayla just described could be considered as part of HRAP because we pull in all these different types of analyses and assessments to kind of help paint the picture for the question. So, for the ask for this bill with reproductive health care services, for example, we may do some additional analyses with the data that the Green Mountain Care Board has and may work with other departments to see if there's other data. But we also know that there's some different measures and metrics that are already out there to kind of add to HRAP to this kind of page it's not really a report, but this analysis of information to help answer the question.
I have one more question and then I swear I'm going to open it up. If we were coming to you sorry to put you on the spot. If we were coming to you without this bill in front of us and said, hey, we want you to help us figure out how we can determine the access and gaps with legally protected healthcare and get that into the community's hands, what would you suggest we do?
I apologize, Chair. I don't know what you mean by legally protected healthcare.
Reproductive health and gender affirming care.
I would probably go to the health department and maternal and child health and health statistics, and I would ask them which metrics and measures they have. I would probably go to the hospital needs assessments, see if this was brought up as a need or a gap. I would call our community providers, probably Planned Parenthood in New England and others, to see if they have gaps or have heard of issues and gaps in care. We could ask our Office of the Health Advocate if they have experienced or had problems helping their clients seek or get access to care. So we've got a whole bunch of different routes at it. It would probably be in Vermont for these services, sort of to what Veronica was saying, especially with gender affirming care. It might be a more useful exercise to go to providers and then to try to see if there's clients who would be willing to do, short meetings to talk about what those barriers are rather than comb through data, because the data might not get at what the access barriers actually are. So if I can explain that with reproductive health, just because it's a little bit more straightforward for me, if you're thinking about access to pregnancy termination and you're thinking about access to care, Vermont technically has the number of providers we would need, right, to serve all the people who would need to access that service. Whether or not somebody can get to that provider because they need childcare or because they need transportation, or maybe they can get transportation paid for, but they don't know how to do that. The barriers might not be the number of providers. And in fact, I think in this case, it's very possible it's not the number of providers that would be a barrier. And so the data that you are talking about, that Veronica's talking about, that we would look at in the profile is not going to actually get you the information you're looking for in that area, because the barriers are going to be ones that are faced by clients that don't show up in claims, don't necessarily show up in surveys.
I will kind of say what Shayla said is spot on. I will just remind that, looking at VCures and VUDs for this is we can do most certainly. But I think it'll have limitations, and for all the reasons I've talked about. And so I don't think it's going to get us answers of where all the needs are or where the gaps are. It's certainly a thing we can try to do, but I think all the ways that Shayla mentioned is going to get more at the root of where those gaps are.
Okay. So I know it's going to involve a conversation, obviously, amongst us, what we do with this section, but I do want to open it up for other questions, and I apologize. I asked so many. Other questions? I asked all the questions. Sure, it helps us, but.
I'm feeling more confused than I was before.
Yes, I have.
Okay, Topper.
If the chair already talked about, if I came to you and asked you for this kind of information, I guess my question is, it is possible to get that information through some of the avenues that you mentioned. Is that correct? We can get the information in terms of access, gaps in access to reproductive health care and gender affirming care. I see one nod. Yes.
That was not a nod. I would defer also to Veronica on this, and this is Susan Barrett speaking from the Green Mountain Care Board. I think that it depends on the data source as to whether you can get the exact information you're asking for. And I would just echo what Shayla shared in terms of beyond the data, there would need to be even a qualitative exercise, to really talk about what the different areas are experiencing and what the consumers of healthcare are experiencing on the ground.
So you feel you can do it. It can be accomplished.
We can, I'm speaking for HRAP here, and I actually think at some point, if we can do this, if Veronica could share her thoughts on how, we talked about this yesterday, how she would update our HRAP in terms of this request, that also might help answer your questions. I don't think, again, that HRAP is going to be the only place that you would want to go for this. But I think that we are taking this back and will attempt to get as much information as possible for you to answer these questions through HRAP.
When is the next HRAP due?
Sure, I can speak to that and just kind of say a little more from what Susan just said. But so HRAP is to be updated every 4 years. However, it's no longer just a single document, so it gets updated frequently. But kind of the new 4-year cycle started in 2023, and so internally we've been working on kind of what kind of enhancements and we want to see in HRAP. I will add that, with HRAP, kind of the framework and process and the structure, it really relies on data sources that are already available to us and the state. And so some of the kind of going out and doing qualitative studies or some of what Shayla was speaking to would take extra funding or staff resourcing, et cetera. It, is not necessarily something that's available to us today, which is really how HRAP kind of is updated. So hopefully that's.
So I mean, someone needs to mute, I think. Let me ask it this way. If we kept this language in here, I'm just focused right now on HRAP, when could you provide a report to us that we could then say, yes, this got us to what we were looking for, or no, it really didn't. And so now we have to figure out, the next best path forward. What are we missing from HRAP that we still need?
Sure. So we discussed this a little bit internally of, what could a time frame be? And I don't necessarily think it'll be a report per se. It'll be a part of the HRAP pages or framework. And so I think, we'll prioritize this work. And so probably by the end of the year would seem reasonable, but I don't want to put like a date on it.
That's fine.
Just, with staffing. But I think it's something that, with the data that we have now is not impossible to do in a semi-timely fashion.
Okay. So we could have something potentially to look at in HRAP when we're back in session at some point next year. Okay.
Correct. Yes.
Yes. Same question to Shayla.
So again, reproductive health broadly, there's a lot of information. Gender affirming care specifically, I do not know of any that is currently reported as data. Again, I would, I think I would ask the committee that if what you're looking for is a gap analysis there, I'm not sure the claims data that we could have access through the Green Mountain Care Board's VCures is specifically what would help this committee make decisions around care and the need for care.
Daisy?
I guess just one thing, just
that's okay.
Off of that. I think it's important to remember that the data that we have, I'm speaking to VCures and BUD, so claims and hospital discharge data sets, are for people who have sought that care. So we might be missing people who haven't sought that care or are uninsured or seek these services outside of insurance. And so we only know of those people who sought that care, not the ones who need it, but
who may not be seeking it. Okay. Daisy?
So I have a question that's just related to 9A. So it's for Shayla. And I'd like to just lift us away from the weeds of, where we would collect the specific data and just kind of pull back and look at what the intent of the language is. So ignoring the community profiles of health and well-being and all of those maps and the health service areas, and just take this for what I'm interpreting it to be. And I know Ledge Council's in here. I don't know if they were working on the development of the language, but to me, this is calling for AHS to embed equitable health access as an indicator, or to embed gender affirming healthcare services as an indicator of equitable health services. Is there another way to do that? Like removing community profiles completely out of the equation? Is it through the scorecards? I mean, I know the scorecards are more a public facing indicator or something that reflects performance of programs. But Shayla, you know how I feel about the scorecards, right? Like I love them. They're totally transparent. They're public facing. You update them much more often. They tie into CMS requirements and all of those things that you cited are happening across AHS in the different departments. So if those metrics are already being collected, is there a way that the agency is measuring equitable access to healthcare that we could embed access to gender affirming healthcare services?
I think my problem here is that I would need to go to the community of people who are seeking that care and understand. So again, we have claims data. That's the only way right now we could get this. And my understanding from the limited amount of interaction I've had with Medicaid, so there's a lot of codes that could be this and a lot of options for how you could view it. I would not want to stand here and tell you what that would be or what that should look like. There is no money or people to do it. So I can't promise that we could do that work. Like Veronica said, I think to do this well, to do it thoughtfully, it would take some pretty good qualitative work up front. And then some ongoing data analysis. And I also love the dashboards and appreciate deeply the amount of work that both DIVA and the health department are the main drivers of the indicators that you're thinking of put into that. But I am conscious that any new workload, especially a workload like this, is not one that I can say yes to for them, because we definitely can't do it at the agency. And so it would be coming from one of those departments. And I have no idea if there's any capacity, and my guess is that they would need more. So I think that's the dashboard idea is a good one. I think my concern is capacity, and I can't answer for them. They would have to come in and speak to that. And again, I don't know what the measures specifically. We couldn't, I will say, to Veronica's point, if you're looking for pregnancy termination data, we could not report that at the community level, most likely.
Yeah, I don't think we would be, I'll speak for myself, wouldn't be interested in that. But I think, a good faith effort in collecting a few different indicators. I know we've seen some great efforts with the public health experts in BDH before, but I think that's what I read the intent of Section A to be. So just moving away from the community profiles, I think it's more about embedding a mechanism to adopt gender affirming healthcare services as an indicator of equitable health access. So it'd be good to explore an avenue to do that within existing systems of the agency.
I think it's both, though. I think it's both, the reproductive part too.
Yeah, yes, thank you. I agree.
Okay, so we're gonna noodle on this as a committee. Thank you both, three of you, for coming back. We really appreciate it. And we'll let you know where we end up with this. Thank you. All right, sorry, I know it's beautiful out. We're gonna keep trugging along here. We now have our wonderful legislative counsel to come up and talk to us a bit about consent.
Is this the last item on the agenda?
This is the last item, and
So less questions, quicker. Not good.
I have a meeting, so we will stop at 4:30. Chair, close chair.
No, I didn't take two to People's Court. I brought a bunch of him with me for bongos.
I thought maybe I saw it. Oh, that's
I found the chocolate supply. Kidding, silly in here.
And we'll talk. Hi. Hi.
You ready for us?
Yes, I'm sorry.
Yes, we consent to hearing about this.
So for the record, Jen Carby, Legislative Council.
Cameron Avergelli, Legislative Council.
So I think I'm going to start out a little bit talking to you about consent generally. I think that, and we're really talking about consent in the context of healthcare services. There are other areas of the law where consent is also an important construct, but here we're talking about healthcare. And I know the question has been asked a lot, well, where is the provision saying that the parents have to provide the consent for certain types of care? And the reason we can't point you to anything is because that is the default. So under our statutes in Title I, 1 VSA Section 173 defines the term, and this is under sort of general provisions for the statutes, defines a minor as a person under the age of 18 years. So they're persons of the age of 18 years are considered of age, and until they attain that age shall be minors. Whenever referred to in the laws of this state, a person who is an adult or who has attained majority shall be a resident or non-resident person of 18 years of age or more. So how does this work? There is really nowhere, I looked around, I tried to find you some case law, some old case law I could point to say, aha, here it is. But it's just a bedrock principle of common law that if you're a minor, you do not have capacity. You are considered an infant. That is the legal term. Even though you can be a 17-year-old infant under the law, you do not have the capacity to make your own decisions unless the legislature has specifically authorized somebody under the age of majority, a minor, to consent. And so just some of the things that I printed out for reference are from the American Jurisprudence, which is a legal encyclopedia. It's sort of, one of the fundamental legal encyclopedias. It's got a whole big section on infants. And so in the very beginning one, it says, while the word infant in its ordinary usage signifies a child of a tender and helpless age, the words infant and infancy as used in law have a technical meaning different from their meaning in common speech. In the law, the word infant refers to a person who has not arrived at majority as fixed by law, and the word infancy as used in law means minority or non-age. And then it talks about minor being a person under the full age, and a minor or infant or minor is a person under a legal disability. So that probably sounds like a strong comment, but that's really what, under the eyes of the law, being a minor is a disability that prevents a person from being able to provide consent or have the capacity to enter into contracts. So often if a minor in some cases, a minor can enter into a contract, but a minor can also disaffirm the contract by saying, I was underage. I didn't have the capacity to consent. So minority is a legal status established by the legislature. So in the absence of an express constitutional inhibition, the legislature has changed the age at which persons reach majority or at which infants are deemed competent to perform certain acts or duties. That is, the age at which a minor is considered competent to do any acts or perform any duties is determined by the legislature. So that is what the blanket 18 years old, you stop being a minor. Under 18, you are a minor. And then it also talks about how the legislature can set different ages for different activities. So when Amron's going to talk to you about the places in the law where legislature has set an age other than 18 for a minor to be able to consent to certain types of health care. That's what that is about. And so just taking a case this is from New York, but it's citing a lot of the same language that I just went through. So it talks again about that same language. I was saying that that infancy since common law times and most likely long before is a legal disability, and an infant in the absence of evidence to the contrary, is universally considered to be lacking in judgment, since his or her normal condition is that of incompetency. In addition, an infant is deemed to lack the adult's knowledge of the probable consequences of his or her acts or omissions and the capacity to make effective use of such knowledge as he or she has. There's a policy to look after the interests of infants who are considered incapable of looking after their own affairs, to protect them from their own folly and improvidence, and to prevent adults from taking advantage of them. And then it goes on to say, accordingly, and this is where I think this is sort of where the crux of this is, accordingly, it has been the common law rule that infants are often deemed incompetent to act on their own behalf and that a parent or guardian must act for them. So under 18 years of age, parent has to act for a minor, except in the instances where the legislature has set a younger age for which a minor can act on their own behalf.
Okay.
So that was level setting to take you up to, and where are the places that we've done that?
Great.
But is that?
Any questions?
That's excellent.
Okay, great.
That's excellent.
All right.
Okay, great. So this document should be posted to your.
Oh, great.
webpage, so you have it if you want to refer to it later, but I'll just talk through it for now. So we have certain provisions when we're talking about informed consent where anyone of, sorry, let me back up. So to bridge over from what Jen was just describing. So the fallback is that a minor's guardian must provide informed consent for their minor child to undergo a medical treatment or procedure. There are certain exceptions. So minors of any age could receive care in these situations. First, an individual of any age, which would include minors, can be treated without informed consent in an emergency. If a person is not able to give informed consent, we say you can still give them care. Next, minors of any age may give informed consent to, first, medical treatment associated with rape, incest, or sexual abuse. It's important to note here that healthcare providers are required to report these incidents to the Department of Children and Families within.
Can I interrupt you?
Yes.
That, what you're reading,
Yes.
did you send that to us?
Yes.
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 On the page.
On the page under A.
Thank you, I'm sorry.
No problem. So minors of any age may give informed consent for medical treatment associated with rape, incest, or sexual abuse. There is a reporting requirement that healthcare providers report these incidents to the Department for Children and Families within 24 hours. Minors of any age may give informed consent to outpatient mental health treatment, including psychotherapy and counseling services, but not prescription drugs as part of that therapy. Minors of any age may give informed consent to reproductive care, including contraceptive devices, termination of pregnancy, prenatal delivery, or other pregnancy care. And so those are the broad ones for minors of any age. I would say most applicable to S37 that you've been looking at are the outpatient mental health treatment, which again is therapy, but no prescription medications, and then reproductive care services. The minors 16 years of age and older may consent to donate blood to a voluntary blood donation program where no compensation is received. Minors 14 years of age and older may apply for voluntary admission to a designated hospital for mental health related evaluation and treatment, but informed consent must be in writing and must include a representation that the minor understands that treatment will involve inpatient status, that the minor desires to be admitted to the hospital, and that the minor consents to voluntary admission without coercion or distress. So minors 14 years of age and younger may admit themselves to a hospital for mental health related treatment by providing their own written informed consent and also a written application from a parent or guardian. And then minors 12 years of age and older may give informed consent to testing and treatment for sexually transmitted diseases, including HIV and AIDS, substance use or substance use disorder. However, if the minor requires immediate hospitalization for treatment of any of these conditions, the parents shall be notified of the hospitalization by the provider.
Good. I'm just wondering if the sexually transmitted disease is a result of rape, incest, or sexual abuse. are they able to give consent if they were like 11 for the treatment?
Right. If it's medical treatment associated with the rape, incest, or sexual abuse, I'm not sure how that has been interpreted by healthcare providers, to be honest. I mean, whether the associated is sufficient enough to say that a minor of 11, well, if the minor is under 12, then they would already be seeking treatment for incest or sexual abuse. You mean if they were to get some sort of sexually transmitted infection from those instances?
Or if they were 11 and they were seeking medical treatment, you know what, it doesn't matter. I'm going off tangent because it's not in the, I'm just like, I'm just gonna.
Yeah, we're done with that.
We're done.
Leslie?
Can you help me understand the difference between, there are two minors, 14 years of age and older? Oh, younger, sorry. I'm tired.
Okay, so that concludes what we have in law for minors being able to give. Otherwise, the default would be a parent or guardian needing to give informed consent.
Let's stop there. Does anyone have any questions on that piece?
Just a general question. These can all be changed by legislation, correct?
Yes.
They're just.
What we have in here.
Okay.
Anyone else?
So just so that I completely understand it, if a 13-year-old wants to have a pregnancy terminated, they can do it without anyone else involved. Is that correct?
Yes. The basis for this is in Title 18, Section 9493, reproductive rights sections that were at, I don't know what year. Do you recall what year?
Reproductive rights, I think it was 2019.
It was a few years ago. So I don't know that it's ever been tested legally, but that is the basis. How people are proceeding is that because the law states any individual and doesn't say an adult or specify age, that any individual in the state.
And could they also seek gender affirming healthcare services?
Not without
They could receive outpatient mental health treatment therapy without medication, but beyond that, no.
Because this thing seems wide open to me. Mental health treatment, including psychotherapy, counseling services. To me, that would fit. I don't know if I'm right, but it could fit in there.
Yes, it does sound like gender affirming care may include therapy.
Yeah.
It has to.
Right, so,
Yeah.
right, but it's no prescription, so next part of the process couldn't happen. It's
The next part,
just
but the beginning
counseling.
could.
Yeah, that's just counseling. I think Art, do you have a?
No, I'm all set.
Okay, Brian.
So these are all of the examples in Vermont law that minors can consent to health care. They're all healthcare related. I keep rereading it before I ask the stupid question. All right. And making sure there's not some other random thing. And we talked about infancy in the legal sense and about consenting to contracts and business and stuff like that. I am wondering, reversing it, are there any situations under Vermont law where adults can force a minor to do something against their consent? Like we banned conversion therapy, for example. But like, is there any examples in Vermont law where adults can make a kid do something that they don't want? I mean, parents are always like, get in your room and like, might put a kid there, but can they legally lock their kid in their room and keep them there against their will?
So we're going to talk about healthcare.
Well, I was using that as an example. Okay, so in this
We could
applying-
do an adult right now if you wanted, Brian.
Which one though?
Across the street,
You're
walk the
offering?
door. No, yeah.
Let's stay on topic. We're getting late.
You could, however, it would be
Let's
considered
stay on topic.
crime. But what I'm getting at is that I was using the parent locking their kid in their room as an example of like doing something to someone against their consent. But where I was going with it was, are there any medical procedures or medical situations in Vermont where a person who's an infant, legally, or a minor, can be subjected to medical care without their consent? I can think of one, but I'm not the witness, but I can say it just to give you what I mean, like involuntary admission, like an EE. In an EE, you don't consent. Like you get put somewhere against your will. Is there any other medical situation? If you don't know today, it's okay. It just comes to mind.
You're speaking of an instance where a medical care provider is recommending to the parent that the child undergo a medical procedure or service.
And the parent can say yes without the kid saying yes?
And that's the circumstances that you're talking about.
Yeah, like for example, could a parent make their kid get surgery for a medical condition when the kid doesn't want it?
Likely.
One child.
I mean, parents have considerable authority to make decisions they believe to be in the best interests of their child. So to the extent it is not expressly prohibited by law, I don't know that there may be ethical considerations for a provider depending on the age of the child and the concern that the child is expressing. And there may be instances where a provider is not comfortable performing a service over the child's objection, but legally, I don't think the child can overrule the parent, except in the areas we've given minors the authority to consent.
But so dramatic. But I'm just thinking about this law. Could a parent if there was a child who's had shared custody with parents between Vermont and a state where transgender treatment has been outlawed or gender affirming healthcare has been outlawed, could the parent from the other state come to Vermont, take the kid, drag them to another state and reverse this gender reassignment surgery? That's the kind of stuff I'm worried is going to be happening.
So there would be no surgery for under a child.
Not always.
Okay, so we're gonna keep going.
Okay, I don't want to get sidetracked too much. I'm sorry. I'm just thinking about we were looking at consent, but to hear a human being would be I don't want you to do that to me, and someone could be I'm your parent, I'm going to do this thing to you. It just still makes me feel for that human. That's all.
So we gotta stay within the confines of this bill for everybody.
Okay.
All right.
It seemed like, yes, it may be more for you, Lori. Was it Jessa Barnard that went over, because I asked the question on number one on one of the pages that brought this whole thing up and said, is it for minors only, is parental permission required? And she said for most things, but not.
This was section 14, I think. This had to do with the disclosure of protected health information.
Yeah.
You asked if the legal representative included the parent.
Right.
Jessa said in most instances, but not all.
Not all.
Yes.
And I wondered, which you have, not all for these mean the mental health piece? Because
Right, so for the things that the minor has the ability to consent to, the minor gets to control the release of information. So I think some of what Ameren has for you on the next page about insurance communications gets into HIPAA, and it relates to disclosure of information as well. So if the minor under our laws can consent to receive the services, then the minor controls release of that information.
Okay. So for the purposes of reproductive health and gender affirming care, reproductive health, minors of any age can make this decision. And for the gender affirming care, the counseling part, they can make the decision?
Right.
Okay.
If they're
All right, just
14?
To understand.
12?
Yeah, no, that's.
Any age,
Okay.
10 years old.
So, yes, so if they can consent, yes, right. If the minor can consent, then the minor can control whether the information gets disclosed or not. If the parent is in the consent position, then they control disclosure as well.
So Wes spoke today about needing parental consent for certain things that I didn't see on this list. So, did I miss it?
Medication.
Their medication, but I wasn't also.
Surgery.
Right.
You have to wait till he's 18.
Right, so if it's not on the list.
If it's not on the list, you need
The
parent
default
consent.
is parental consent.
That's right, thank you.
So you don't have to wait till you're 18, Leslie. You just need to have parental consent.
Right, okay, thank you, just for that clarification.
Okay, next section. Or did we do?
Okay. This actually is a good segue over to a very high level overview about confidentiality of information for minors and insurance communications. We recall there was a witness that was mentioning that a minor may be able to receive their insurance related communications about their healthcare services directly to the minor rather than it going to the parents. And so there's the question, what is the legal basis for allowing that? And so the answer to that is HIPAA, right? The
Federal
Portability and Accountability Act of 1996 privacy rule. This is federal legislation that says unless modified by state law or other law, and now I'm going to paraphrase this next part because it's a very long section, a minor who has the authority to consent to a healthcare service has the same authority to restrict the use and disclosure of the minor's protected health information related to that service as if the minor were an adult. So the remainder of the HIPAA provisions explain how an individual, in this case, which could include a minor who is able to consent to the services themselves, is able to restrict their health information. So the HIPAA privacy rule requires that covered entities, which would include health insurance plans, permit an individual, in this case also a minor, so long as they can consent to the healthcare services on their own, to request that the covered entity restrict uses or disclosures of PHI about the individual to carry out treatment, payment, or healthcare operations. So the key piece being here that the individual actually has to proactively request that there be a change in how things are done and how the insurance plan would normally proceed. And HIPAA also provides that a health insurance plan may, but is not required to, agree to the requested restriction from the individual, with one exception, that a health insurance plan must accommodate a reasonable request by an individual to receive communications of protected health information from the insurance plan by alternative means or at an alternative location if the individual clearly states that the disclosure of all or part of that information could endanger the individual. So that is the only instance when the insurance plan has to agree with a reasonable request to restrict how they're communicating. Otherwise, it's just up to the insurance company whether they agree to the request. So that is why you might be hearing that a minor is receiving some health insurance information where the parents are excluded. There are lots of exceptions under HIPAA where there are disclosures that have to occur regardless of what the individual asks for. Probably the classic example is situations of abuse, right, and mandated reporting. There's also certain litigation exceptions if the insurance company or the provider is being sued and needs to be able to defend their claim. They need to be able to show the patient's service records for some reason as part of the lawsuit. So there are a certain number of exceptions under state and federal law, but the basic idea is that so long as the minor can consent to the care, then they control what happens to the information and can request that the insurance company alter how they would normally proceed with disclosing the information. And then the insurance company may
do it, may have to do it.
Except for that one time.
May not, shall.
Okay.
Yeah.
Does it make any sense to reference this in the bill? Just
That's a legal question. I'm not sure it,
maybe not, not the whole thing.
right?
I don't know what a reporter would say about it.
I mean, I think, as Jessa mentioned yesterday, HIPAA is a floor, so this applies
Okay,
regardless.
yep, yeah, that's fine.
Yeah. Lori's going to report the sections of the bill, so she'll be ready to answer questions.
What section?
All the sections.
Oh,
So I was just wondering how an individual knows that they can request that a covered entity restrict uses or disclosure, particularly a minor. How do they know that?
Okay.
It may be in the HIPAA release that you sign when you go to the provider. It's been a long time since I've read one of those.
Right, yeah.
I'm curious if primary care may sometimes talk to teens about some of that, maybe. My
I
child knew.
yeah, that's
She didn't
interesting.
ask to request it, but she's just like.
Oh, she knew?
She did.
That's my son.
Yeah.
Yeah.
She knew she had her like 16 checkup and it was just like, well, those are my records and I'm not gonna take it away from you, but you can look at them. But, so I never told her.
Right.
My first consent training is today.
As likely teenagers are sometimes ahead of us on some things.
I
Yeah.
probably Googled it.
Yeah. Last thing in the.
No, I was just gonna say that as a provider or somebody who's worked in HIPAA and then that happens all the time, but I never ever knew that you could ask the insurance company not to send information. I'd never heard of that before. So I don't know how
much is used.
12-year-olds are figuring
that's
that
what I
out. Yeah. But their providers aren't telling them that.
This was very helpful. Thank you. Yeah, very helpful and for posting it on the page. I think that helps, clears up a lot of questions.
I love it. I can call my 17-year-old infant.
You're legally an
You're legally an infant.
So we are back here tomorrow at 9 a.m. with Jen and Aaron again. And we're gonna walk through the bill, right? And start making some policy committee decisions. So be ready for that.
So an updated version?
We'll walk the chair. Oh, yeah, so I think we'll probably have it ready in the morning. I know Jen and Aaron, I think, still have some work to do on it, so.
That would be great. And then if we could get another copy,
Yes, we can ask Claire to print some copies.